majorly the orthopedic part of this metabolic bone disease associated with these 4 common conditions. First, we'll go to scurvy. We know it is happening because of vitamin C deficiency, otherwise known as Barlow's disease. The clinical presentation is a generalized hemorrhagic tendency, the general tendency to bleed. James Lind in 1753 treated scurvy by giving citrus fruits, as it was scurvy was commonly found in the voyagers who are on long voyages on sea, and they used to strive on grains and the meat and fish for their food for long duration for years together, leading to vitamin C deficiency, which is present only in fresh vegetables and fruit. So why vitamin C is important? Because it is required for the hydroxylation of proline and lysine as cofactors with the enzyme hydroxylase, which is essential for the collagen synthesis. So if there is a vitamin C deficiency, the collagen formed is abnormal. Sometimes both vitamin C and D can be co-deficient, which is otherwise known as Barton's disease. Usually, it is seen in children, especially who are having a mental disorder like CP. They are difficult to wean off from the breast milk or milk and some sort of food which is not doesn't have vegetables and fruits. If they are striving on other kind of fruits for long duration, this kind of children, especially with CP, develop scurvy in the current days. Apart from that, we can see these features in psychiatric patient, like some sort of schizophrenics who remain difficult. They have dietary issues for long duration. You can see scurvy in anorexia nervosa. Otherwise, scurvy is largely disappeared from the modern society. Usually the child is restless, pale, febrile, having pseudo paralysis, that is because of the swollen, bleeding, painful joints. The child is not moving the legs or upper limbs. There are epiphyseal separation affecting the lower femur, upper humerus, or upper tibia commonly. There will be costochondral separation, that is also a joint, costochondral joint separation, leading to formation of scorbutic rosary. There can be bleeding gums, bluish appearance, and spongy swelling around the central incisors. Ecchymosis and petechiae in the skin and mucous membrane, hematemesis or hematuria. There may be anorexia, weight loss, progressive anemia, hyperparathyroidism, and pneumonia even can be fatal. So these are some clinical pictures showing gum swelling and bleeding, the scorbutic rosary on the right side picture. The classical presentation is in the bones. So there will be subperiosteal hemorrhages, and when it is near the metaphysis, it can reduce the osteoblastic growth and disturb the ossification and weakens the epiphyseal-metaphyseal junctions, leading to separations. There will be bleeding throughout the marrow and replacement with fibrous tissue, leading to anemia. So capillary hemorrhages can happen in gum, skins, conjunctiva, intestine, and bladder. These are some classical pictures in an X-ray of patient with scurvy. We have a ring sign of Imberger, corner sign of Park. I will come to that further details. Trummerfeld zone of calcification, a white line of Frenkel, and ground glass appearance in the metaphysis and penicillin thin cortex. This is what is seen in the long bone. So what are these lines? The Imberger line of Frenkel, it is actually a white line of calcification between epiphysis and metaphysis. The Trummerfeld zone or scurvy line, it is radiolucent cortex proximal to the white line. It is better visible in the previous picture. You can see the white line and a radiolucent cortex just proximal to it. So Imberger or signet ring sign, in which there is a sclerotic line encircling the epiphysis. The corner sign of the pelican spurs are the spur from the lateral border of the metaphysis here, and which is because of infarction and healing. The ground glass appearance or rarefication of the metaphysis. Scorbutic rosary I have already mentioned. The raised periosteum usually lead to a periosseous calcification. You can see in this picture this raised periosteum and the florid calcification which happens inside it. There will be separation of the epiphysis. The cortex are thinned, pencil thin cortexes. These are the common radiological pictures. So the laboratory test is based on the blood leukocyte ascorbic acid levels, which is less than 0.5 milligram per deciliter, which is tested from the buffy coat of the centrifuged blood. And the treatment is vitamin C supplementation, usually given as in tablet forms, 250 milligram 4 times a day in a florid vitamin, florid scurvy. And fruit juices, fresh fruit juices, especially lime or orange, can also help to build up. So this is a common difference we must know between the rachitic rosary and scorbutic rosary. The rachitic rosary are non-tender, they are nodular, and they are due to enlarged metaphysis, which happens in rickets. But scorbutic rosary is tender, they have a sharp step up because there is a physeal separation, and it is because of the costochondral separation. This is the classical difference between the two types of rosary. So now we proceed to rickets. So rickets come from a old English word known as twist, and rachitis means deformity of spine. So rickets actually means a hunchback deformity of the spine. So it is otherwise known as English disease, as described by Daniel Wishler early in 16th century. Commonly they present in between the early infantile age, 6 months to 2 years, because that's the period when the child is weaned off from the breast milk and start taking normal food. If there is, and the child also grows quite rapidly. So in this time, if there is a deficiency of vitamin D, especially from the dietary, from the milk, from the sunlight or other sources, then they can develop this kind of infantile rickets. Fetal rickets is rare unless the mother is severely osteomalacic, and many rachitic forms which present later beyond the age of this dietary age group, they are known as rachitic trada because they present slow or late. And more commonly, it is because of vitamin D deficiency rather than calcium deficiency. Calcium deficiency is less common in children. So this affects the active endochondral growth area. There is failure of mineralization leading to soft and a deformed bone, which leads to various deformities. So if we go to the details of the etiology, it can be nutritional or non-nutritional. For the non-nutritional group, it can be a deficiency state. There is less intake. It can be less intake because of lack of vitamin D. It can be dietary. It can be resorptive or absorptive because GI absorption is poor. It can be less sunlight, or can be some skin disorder like some pemphigus-like disorder. So the skin actually is thick and doesn't allow the sunlight to penetrate to form vitamin D. It can be calcium deficiencies related to even drug intake, which can chelate the calcium apart from dietary or absorptive issues, or it can be phosphate deficiencies. It can be because of various gastric causes, because of decreased acid production, decreased fat handling, or enteric disease. But these are more commonly seen in osteomalacia rather than children. Non-nutritional group of rickets is an entirely different group, which manifests almost same, but usually a bit late in presentation, and that will come later. So deficiency rickets, the clinical features in a florid scenario have the whole body have some changes starting from top to toe. From the skull, you have bossing, frontal bossing. There can be generalized softening of the bones, which is otherwise known as craniotabes. You can feel the skull bones are soft. The fontanelle remains open for the longer time. The sutures remain wide. The skull looks like a hot cross bun or a caput quadratum. That are the two. The sagittal and coronal fissures remain open, and it looks like a hot cross bun and late fontanelle closures. In the teeth, we have late dentition, poor mineralization, they're repeating and grooves on the teeth, hypoplasia of enamels, early caries, and waddling gait. The gait is waddling because of two things. There can be a proximal myopathy, is a quite common cause of gait waddling, and second can be coxa vara, which is also a deformity in the hip, leading to causing this waddling gait. In the thorax, there will be scorbutic and there will be rachitic rosary, which are rounded, smooth, and non-tender, like this. And there will be a pectus carinatum, rarely excavatum, but mostly carinatum. The sternum protrudes outside. There will be Harrison sulcus. Harrison sulcus is basically a groove appearing in the rib cage along the attachment of the diaphragm. Then an abdomen, there can be pot belly, and the thoracic kyphosis, which is otherwise known as rachitic cat back, and there may be lumbar lordosis. So if you come to extremities, which is what is commonly seen in the knee is a genu valgum, when the knock knees, or genu varus, or rarely a windswept deformity. So whether a child is developed in genu varus or valgus, it depends upon the age of onset of the deficiency. Because initially when the child is born, they have a varus knee. So in the first 2 years, if there is a dietary deficiency leading to rickets, these children come with mostly varus deformities. In a normal physiological growth of child, the varus becomes neutral to valgus around at 4 years of age. So if the child have a late onset rickets around after 4 years of age, they are more prone to develop valgus deformity. The exact mechanism of development of windswept deformity is not known. Then rachitic saber scene. The scene becomes very prominent, blade-like or sword-like in some long-standing rickets cases. The tibia becomes bowed. In the hip, the patient develops coxa vara. The long bone ends are enlarged. This is the commonest clinical sign seen, especially in the wrist, where the enlargement of distal radius and ulna physis, leading to early suspicious of rickets. In the ankle, they give rise to a appearance of double malleoli. There is string of pearl appearance or a sausage-like enlargement of the ends of the phalanges and metacarpals of the corresponding joints. There can be a wizened look, irritable child, muscle weakness, especially the proximal myopathy because of calcium related metabolic issue. Even patient can land up in tetanus and convulsions in severe cases. So what happens actually in the bone? So if we see a normal bone, these have various layers in the physis, starting physis to metaphysis, the area from which the bone growth happens. The resting and proliferating zones in rickets are normal, but the maturation zone get affected. So in a normal bone formation, we can see this zone of maturation is not that thick, but this is resting zone, this is proliferating zone, this one, and this is maturation zone. So that is not thick. But in rickets, what happens because of there is less mineralization, the hypertrophic zone starts increasing in width. There is no calcification, and these hypertrophic chondrocytes are not resolved due to defective apoptosis, and unmineralized deformed osteo tissue starts accumulating, leading to widening of the growth plate, this zone of maturation. So there will be disorder proliferation. The normal columning is lost. This is normal columning. Here it is disorder here and there. And marked increase in axial height. The zone widens. Then profligate profusions of the cells, that is the cells start moving here and there, and lack of osteoid mineralization. On an X-ray, the classical features is widening of the epiphyseal plate. See both the radius and ulna, they are widened. Cupping. Cupping means this excavation-like appearance. This is cupping, more prominent on ulna, or trumpeting. That looks like a trumpet. Fraying. You can see some lines from the metaphysis towards physis. This irregular lines is known as fraying appearance. Splaying or flaring, it is similar to widening when the metaphysis is widened or flared. So this fraying can give rise to a paintbrush appearance because there looks like the bristles of a brush. The metaphyseal spur, this widening in the metaphysis can lead to appearance of a metaphyseal spur. And or we can say this is like a champagne glass appearance of the long bone ends. Almost same thing have been described in different ways. The epiphysis is usually delayed in appearance and mottled, irregular, and well defined. And the theory behind is known as piston and cylinder theory. That is, when the loading happens, the epiphysis starts pushing this soft zone of mineralization, leading to this widening cupping or splaying appearance. Fraying happens because of the disorder mineralization. Some amount of mineralization happening and some mostly not happening. So these are other pictures of the rickets. You can see clearly the changes what we have described in florid cases. In minor cases, we may not have these kind of florid pictures, but some amount of widening, some amount of metaphyseal breaking can be give rise to high suspicion. And there is a paradox in rickets that severe cases with systemic illness, those who have hypoproteinemia and poor nutrition, they have less radiological signs of the rickets. So many severe cases we may not have classical pictures. So that is a rickets paradox. Usually investigate with the biochemical parameters. The calcium usually normal or low. Phosphate is usually a bit low, but the diagnostic is alkaline phosphatase, which is increased. Though in normal children during growth spurts, the alkaline phosphatase can be increased even up to 500 international units. So you have to very well judge clinically, biochemically, and radiologically to stamp a diagnosis of rickets. The cutoff of ALP can be up to 250, 300 units, but sometimes in the growth spurt it is even normally higher than that. So that is what we need to keep in mind. Bone biopsy is not done, though if we can see some pathological changes like wide osteoid seams and defective mineralization on tetracycline labeling. So, but this is not required in any case for diagnosis. So we can think of getting a urinary calcium test for the sulcois test, and normal urinary calcium is 400 milligram per day, or when there is a kidney threshold for a serum calcium is 7.5 to 9 mg, there will be faint turbidity in this test. But these are rarely used. Just you need to remember the name sulcois test. You can go for urine phosphate and the percentage tubular resorption of the phosphates, serum vitamin D2 and D3 level assays. These are mostly done in case of non-nutritional rickets to find out the other causes rather than for the nutritional rickets. The usual treatment for a nutritional rickets is the vitamin D supplementation. We can give it orally 60,000 units for a week, or even nowadays they have preparation oral drops for the children, nano drops. This can be given. The total dose is given is 6 lakhs units, and if no response is seen in 4 weeks, the dose can be repeated. And those who don't respond even after 2 doses, radiologically there is no healing, we label them as resistant rickets. We can add on a calcium and phosphate supplementation. Phosphate supplementation is more important in hypophosphatemic rickets or vitamin D resistant rickets, and some patients with renal disease might require a sodium bicarbonate or alkali supplementation for renal tubular acidosis. The not nutritional group is quite a large group of rickets, though they present very rare So it can be related to vitamin D metabolism or can be related to renal tubular causes. The other causes are unusual. The vitamin D metabolism related is one is VDRR, that is vitamin D dependent rickets VDDR1, where there is a deficiency of D1 hydroxylase, 25 hydroxy vitamin D1 hydroxylase enzyme, and VDRR2 when there is a end organ sensitivity. There is end organ insensitivity in VDRR2. There is vitamin D, but it is not working. One is because of lack of enzyme of hydroxylation, and one is because of the receptor level insensitivity. It can be acquired in CRF, chronic renal failure, anticonvulsants, fibrous dysplasia, or neurofibromatosis. Then the renal tubular rickets have one group is known as vitamin D resistant rickets or hypophosphatemic rickets, which require phosphate supplementation. The Fanconi's group of syndromes where there is this hypophosphatemic rickets with glycosuria and aminoaciduria. That's a syndrome of three things. Then renal tubular causes known as renal tubular acidosis. It can be distal renal tubular acidosis and various syndromes like Debré-de-Tony-Fanconi syndrome, Lignac-Fanconi, Lowe, or hyperglycemic syndromes. Other causes can be hypophosphatasia, that's a separate entity, etidronate, or fluoride therapy. So flurosis can have presentation like rickets. Hypophosphatasia is a different thing in which the alkaline phosphatase will be normal, but the presentation is like rickets. So this type 1 vitamin D, where there is enzyme deficiency, there is calcitriol or vitamin D deficiency is given. Calcitriol or vitamin D3 is given to supplement. In type 2, the classical clinical picture have a alopecia, milia, and epidermal cysts. They have a receptor level mutation leading to end organ resistance, and the dihydroxy vitamin D levels are higher, almost 3 times. But when the vitamin D3 is given, they may respond, though the response is sometimes unpredictable. So the other VDRR or phosphate X-linked hypophosphatemic rickets, usually genetic mutation in the X chromosome, and they have onset slightly older age. They usually present somewhere around 7, 8, 9, 10 years later during the growth stages, and they develop severe angular deformities and short height. And their manifestations are almost similar, though they have more nephrocalcinosis and more Harris lines is classical, which is seen in irregular sclerotic lines in the metaphyseal area. They need phosphate supplementation apart from the vitamin D3 or calcitriol. Renal tubular acidosis, they have the major problem is failure to acidify the urine, leading to hyponatremia, hyperchloremic, or hypokalemic acidosis. Fanconi syndrome, it is also nephrocalcinosis leading to hypocalcemia. These presents with mostly renal calcifications, calcium phosphate stones, and these chronic acidosis decreases tubular absorption of the calcium, leading to this kind of skeletal pictures. This Fanconi group of syndromes also have various types, and they have like proximal renal tubular acidosis, they have a proximal Fanconi syndrome, they have a Debré-de-Tony-Fanconi syndrome, Lignac-Fanconi syndrome, Lowe syndrome or oculocerebrorenal syndrome, and superglycemic syndromes. Though these are mostly associated with metabolic, genetic related metabolic problems, and always there is a phosphate defect, resorption defect, and they present with dehydration, acidosis, hypoproteinemia, and the skeletal pictures of severe rickets. Hypophosphatasia is an autosomal recessive genetic error where alkaline phosphatase is not synthesized in the body. So there will be rickets with normal alkaline phosphatase levels. So the diagnosis is based on increased phosphoethanolamine levels in the urine. The next group is osteomalacia, which is adult counterpart of the rickets. Here the skeletal pictures are very rare. The patients usually present with fatigue, back pain, joint pain, muscle weakness, waddling gait, leading to difficulty in rising from chair or walking, and maybe signs of hypocalcemia like Bostic sign. So this is seen in mostly in the adolescent or adults. It can be nutritional, low sunlight. It can be because of multiple pregnancies, what we see in our clinical practice commonly, associated with chronic kidney disease where there is reduced alpha hydroxylate enzyme, or phosphate wasting because of acidosis. There can be chronic liver disease, GI related malabsorption, Crohn's disease, or patients on chronic bisphosphonate therapy. It can be the paraneoplastic oncogenic with various tumors like hemangiopericytoma, cytoma, or VBNS or GCT. Rarely with other condition like cadmium disease or Ita disease reported. If we investigate them, they have low calcium or normal calcium levels, marginally low. Phosphates are low, alkaline phosphatase is low, and serum vitamin D levels are definitely low. The parathormone levels can be increased because of the secondary hyperparathyroidism. From the orthopedic point of view, they present with some classical radiological pictures apart from the clinical picture of waddling gait, lethargy and apathy, difficulty in rising from sitting position, or long-standing proximal myopathy. And on X-ray, we see there is a diffuse demineralization of the bones where the trabeculae are erased, looking smudgy or fudgy appearance. The trabecula becomes coarse, and there can be stress fractures or insufficiency fracture. You can see in this X-ray there is a stress fracture in the neck. There is something known as Luger's zone or milkman's fracture or pseudo fracture or Ambau zones. They are usually unicortical fractures on the compressile surface or the concave surface of the bone. They are transverse and symmetrical on the both the sides. Commonly seen in the neck of the femur, axillary border of the scapula, or the pubic rami. It happens. It is supposed to happen because of the presence of some pulsatile, some blood vessel around the bone in these particular zones, and because of the pulsation of the artery, there is early decalcification of these areas, leading to leading to this radiologic phenomenon of pseudo fractures. In spine, the vertebra becomes biconcave or codfish-like. The pelvis becomes triradiate because of the soft bones gradually leading to protrusio acetabular, and the pelvic becomes triradiate type. So sometimes these pseudo fractures can lead to complete fractures in osteomalacia, like in this picture. They are bilateral. They are usually bilateral, symmetrical, or maybe lagging one lagging behind the other. So most of these osteomalacia patients, they need to be clinically and radiologically diagnosed. They are treated with vitamin D supplementation of total dose of 6 lakh units. We can give them oral 60,000 units of sachets or nano shots weekly basis, and or in severe cases like the patients who have signs of hypocalcemia like Bostic signs or a Coucher's hand, they have spasms in their hands. Those patients also respond tremendously to injectable vitamin D and calcium supplementation. Once we reach to a normal level of calcium by we taste repeat the taste after a month or so to see the levels of vitamin D, normal level of vitamin D is reached, and then we supplement them on as per the daily requirement or a bit higher than the daily requirement. The daily requirement is around 1000 intracellular units. We usually supplement this kind of osteomalacia patients with 2000 intracellular units for some more time, maybe 6 months to 1 year, with interval testings. The next part is osteoporosis. We come to osteoporosis. What is osteoporosis? Osteoporosis is actually diminution of bone mass or unit volume of normally mineralized bone. So till now we have discussed rickets, osteomalacia, where mineralization is defect. But in osteoporosis, the mineralization is normal, but there is loss of bone mass per unit volume. So WHO defined the bone density that falls below the 2.5 standard deviations below the mean young healthy adults of the same race and gender, which is known as T-score, less than minus 2.5 as osteoporosis. So it can be primary osteoporosis or secondary osteoporosis. If you see the pictures, the history of the same unit, we have more trabeculae in a normal bone which are thick, whereas in osteoporotic bone the trabeculae are less, thinned out, leading to loss of bone mass. There is no defect in mineralization. So primary osteoporosis is type 1, known as postmenopausal osteoporosis, where there is loss of cancellous bone, or otherwise called high turnover osteoporosis because of rapid loss of cancellous bone. The type 2 is senile osteoporosis, which is seen in females of later age, more than 70, and males after 50. They have excessive loss of calcium as well as cortical bones. So type 2 osteoporosis is known as low turnover osteoporosis. So type 1 has got more predilection for the cancellous bone, so they have more fractures like wrist fractures, whereas type 2 affects both cortical and cancellous bone, so they affect more trochanter and femur fractures. The primary osteoporosis have decreased bone density, so there is decrease in not only the calcium deposition part, also there is decrease in the protein matrix in which the calcium is laid down. The rate of resorption increases, so the rate of resorption is actually increased over the amount of bone formation. So vertebra, in the vertebra, what we see is loss of horizontal trabeculae. That is one of the earliest signs. The dorsal vertebra becomes wedge shaped because there is a normal thoracic kyphosis. The anterior height starts decreasing and leading to anterior compression fractures. The lumbar vertebra becomes biconcave, like codfish, and there is ground glass appearance of bone on X-rays. In secondary osteoporosis, which is more diffuse because cortical and cancellous both are affected, it is associated with dietary related anorexia nervosa, alcoholism, malabsorption, drugs like heparin, steroid, ethanol, methotrexate, lithium, phenytoin, warfarin, and also PPI, proton pump inhibitors. That is what we must remember, because we commonly give proton pump inhibitors to patients with pain for chronic therapy, and their calcium absorption is vastly reduced, leading to secondary osteoporosis. Endocrine hyperparathyroidism or hyperthyroidism, hypercortisonism, chronic illness like rheumatoid, sarcoidosis, and some genetic issues like osteogenesis imperfecta, Marfan's, hemochromatosis, then neoplastic, or some idiopathic causes. They present with fragility fractures. So that particular term, fragility fractures, is used in relation to osteoporosis, which can affect hip, can lead to fracture in the neck or trochanter, can affect the vertebra leading to compression fractures, can affect wrist or ribs. So the evaluation of a vertebral fracture in an osteoporotic patient which comes to OPD, what we need to screen before we label it osteoporosis. First, the mnemonic is TOMIO. First is tumor. So we must screen them for tumor by X-ray, bone scan, MRI, clinical evaluation for other sources of the tumor, taking proper history of the bleed or some mass somewhere. Then we go for an osteopenius screening or DEXA scan. We can go for a marrow screening if we find some amount of some issues in the blood counts, ESR, or we can think of serum electrophoresis for myeloma, which commonly mimics this vertebral fracture osteoporosis. endocrine screening for parathyroid, thyroid, cortisol, and osteomalacia screening for the rickets. So basically, we must keep these differentials in our mind before labeling a vertebral fracture purely as osteoporosis. So the measurement of bone density or DEXA scan is the gold standard to label a patient of osteoporosis, osteopenia. So the results are expressed in relation to two values. One is T score, one is Z score. The T score is related to young population of the matched race and gender, whereas Z score is the age matched population of the same race and gender. So Z score is more specific, whereas T score is taken as the definition in WHO. Quantitative CT can be the higher investigation in beyond DEXA, which is rarely used. Then body neutron activated analysis, ultrasound, biopsy, this can rarely be used, but they are scarcely used in clinical settings. This is how a picture of a DEXA actually comes, the DEXA scan. So from the area of the neck, you can see the mark has been given. From that area, neck, they have measured the BMD. This is Ward's triangle, this is trochanter, and this is shaft. So this they have taken an average, and the average is minus 2.3. So this way the report comes, and this is the BMD, and this is the age. So suppose a 60-year, and then the 70-year, the point is somewhere here, which is below minus 2. So this is in not in a florid grade. This is in the risk group. Below 2.5 is a osteoporosis diagnosis is established. So what drug treatment we usually give? We start with the vitamin D and calcium supplementation. Apart from that, we need to start on anti-resorptive agent, that is to reduce the rate of bone resorption. The commonest drug used are bisphosphonates. In postmenopausal patients, we estrogen analog or hormone replacement therapy. Then raloxifene, calcitonin can also be used in rare cases. Calcitonin is commonly used in vertebral fractures, for that also reduces pain and early mineralization in vertebral fractures. We can add on anabolic agents, that is increase bone formation. First is to reduce resorption, second is to increase bone formation. We give calcium and vitamin D. People have tried sodium fluoride, but no more used. And then teriparatide, that's a recombinant parathormone, which can be to increase the bone density. The newer drugs include donizumab, which is a monoclonal antibody against the rank ligand receptors, and strontium granulate. Bisphosphonates are commonly used. They have their various names, alendronate, risedronate, ivandronate, and tolendronate. So the first three are oral. The alendronate and risedronate can be given on weekly basis or even daily basis. But ivandronate is given on monthly basis. Jolendronate is available as IV infusion, which is given once in a yearly for a diagnosed osteoporotic patient. During the infusion, we need to take care that the patient should not develop hypocalcemia. We need to monitor the heart rate, and we can preload the patient with some calcium gluconate or oral calcium prior to the infusion. The commonest drug reaction because of alendronate or risedronate therapy is esophagitis. So we ask the patient to take a glass of water in empty stomach when they take this weekly dose of bisphosphonate, and the patient should not lie down for an hour. So that that reduces the risk of esophagitis. It is associated with jaw necrosis or insufficiency fracture or atypical femoral fractures because of R dynamic bone disease, because the bone is a organ which is a dynamic in nature. They have regular formation and resorption going on. So if we stop resorption, the bone reaches a state where there is a dynamic state. So because if we see the Along the straight lines of the bone formation and desorption goes on to form the trabeculae. If they are not formed properly, they are not replaced in regular way, then that area becomes gradually dense on the X-ray, but actually it is weak because the trabeculae are not formed properly and lead to insufficiency fractures or atypical femoral fractures. So in spine, if patient have multiple levels of collapse and severe collapse, patient can be offered even a surgical kyphoplasty in which bone cement is injected. The spine is into the vertebra, which reduces pain and allows early mobilization. So this is a table showing the difference between osteomalacia and osteoporosis. So the osteomalacia patient apparently ill, whereas osteoporosis patients are not actually ill looking. Osteomalacia patient, they have a chronic generalized ache, body ache, back pains, hip pains. But osteoporosis patients becomes painful only after they develop a pathological fracture. In osteomalacia, there is muscle weakness. Patient is difficult to rise from a sitting position, difficult to do long standing. But osteoporosis do not have any muscle weakness. Osteomalacia have looser zones, and osteoporosis doesn't have looser zones. The alkaline phosphatase is increased in osteomalacia where it is normal in osteoporosis. Serum phosphorus is reduced in osteomalacia where it is normal in osteoporosis. And the calcium into phosphate, the ratio, it is also used for a diagnosis. It is less than 2.4 millimoles and it is more than 2.4 millimoles in osteoporosis. So this is a gross table comparing the calcium, phosphate, PTH, 25 vitamin D, 125 vitamin D levels, alkaline phosphatase, urine and calcium and phosphate among this various group of vitamin D related disorders. So we must just see where is the changes happen. So in vitamin, so if you see the calcium levels are mostly normal to low in most of the disease. Okay, but and phosphate levels are usually low and they're severely low in renal tubular acidosis, and phosphate retention happens in chronic renal failure. PTH is increased because of secondary hyperparathyroidism in vitamin D or calcium deficiency, where it is reduced or normal in phosphate deficiency because phosphate have an inhibitory effect. Again, it is increased here secondary hyperparathyroidism, and 25 vitamin D levels are reduced in vitamin D deficiency but normal in the rest. The 125 hydroxylated vitamin D levels are increased in these diseases. Vitamin D deficiency can be anything normal to increase to decrease, but in calcium, phosphate and other vitamin D resistant aggregate, it will be increased. Whereas the VDRR or renal related, CRS related, it will be reduced because these are the kidney disease or kidney receptor defects or kidney enzyme defects. So in that case, when the renal hydroxylation, the vitamin D hydroxylation happens in the kidney. So in the kidney related disease, the vitamin D 125 will be reduced. Otherwise, it will be normal or increase secondarily. Alkaline phosphatase is always increased apart from hypophosphatasia. Hypophosphatasia is a genetic defect in alkaline phosphatase formation. So alkaline phosphatase is reduced or normal. Urinary calcium levels, if there is a deficiency in the body will reserve more, leading to less excretion in the urine. But it will be increased when there is a phosphate deficiency or a renal related issue. Similarly, urinary phosphate will be increased in vitamin D deficiency and most of the disease apart from the phosphate deficiency. When there is a phosphate deficiency, there will be the phosphate will be more resolved. So that's why it is reduced in urine, and in this CRF also the phosphate urinary is reduced. Now it's basically a phosphate retention scenario. So this is a gross table we can memorize or remember to go through all these disorders biochemical parameters. I hope I'm over. Thank you. Any questions? कोई किसी ने क्वेश्चन डाला है कुछ? Okay. Why costochondral separation? Costochondral, basically costochondral joint, it's a like the long bones have a epiphysis and metaphysis. This costochondral is also like a sort of bone and cartilage junction, right? From where the rib actually grows. The long bone grows from the physis, the rib grows from the costochondral junction. So that have the same anatomical pictures of a physis. So once the way it is physis is affected because of the increase in zone of hypertrophy, and there is a slip because the disorder arrangement and the weakness, there is a slip. The same way the rib have a slip at the costochondral junction. So that's why this is affected in scurvy. In rickets, it is affected like a metaphysis. In rickets, we see metaphyseal changes like cupping, fraying, and splaying, widening. This widening also affects the costochondral junction in the same way. Why ALP is low in osteomalacia? Osteomalacia to nahi. Osteoporosis mein low. It is low in normally in osteoporosis. ALP is not low in osteomalacia. Did I say it like that? Osteomalacia ALP. Let me check. So not here. Okay. Stimulation, yes. ALP is low, yes. I think ALP is not low. This may be a misprint. ALP should be increased in osteomalacia, but usually they have increased, not low. This is a misprint. I need to correct. Yeah, it should be increased rather than low. Difference between stress and fragility fractures. Okay, stress fractures are in osteomalacia, which happens, or it can be even in a normal bone. Stress fracture is because of the actual definition of stress fracture have a lot of things. If the stress is more in a normal bone, like a sportsman having a runner fracture, so the stress is more in a normal bone can lead to stress fracture, and a normal stress in an abnormal bone can lead to stress fracture. The abnormal bone can be osteomalacia, can be anything, right? So if this kind of stress fracture in osteomalacia, that happens mostly on the concave surface. Concave surface have a stress transfer, or which is the tensile surface, right? So they usually present like a looser zone, but once this fracture proceeds to the other level, that other side till the compressile side, then it can lead to a complete fracture. So that is a stress fracture. Since it is on the compressile side, if we supplement them properly, this will heal on its own, because the body weight compresses the compressile side, not the tensile side. Whereas the next group is known as fragility fracture. Fragility fracture is actually the bone fragility is related to osteoporosis, where there is decrease in the bone mass. The bone mineralization is not defective. The bone mass means both the calcium and the minerals and the bone proteins and the collagen, everything is deficient in the bone. So the bone is inherently weak. So with a small fall, patient can develop a fracture in the distal radius, can develop fracture in the neck femur or a trochanter. So that is fragility fracture. Piston theory again. Basically, this is the normal loading of the bone. So the suppose imagine a distal radius. So the child is pushing or walking or playing or on his palm. So the physeal plate gradually pushes into the metaphysis. The metaphysis is into the metaphysis, and the intervening zone of hypertrophy is weak. So that pushes in, leading to widening of this metaphysis. So that is the piston and cylinder theory. There is a diagram, I forgot to put it here. You can search it from internet. There is a diagram that a cylinder and a piston like a syringe. Once you push the plunger, the things go out from the sideways. Do you have time? No. Okay. We finish here. Thank you so much for the patient hearing.